I cannot thank you enough for coming. I mean, we have, the big hitters from Division of Research here and department chairs and PIs and faculty fellows and new faculty and postdocs. And the one thing that brings us together is probably, if I could guess, that we have an interest in research and applied research specifically that relates to a health issue or health and resilience. Our center is focused on all types of health research, and we have the pleasure of working with faculty fellows from almost every college, I would say. So we are in the process of doing several projects this year. And what we do with the fellows is support their work, and based on their expertise and their goals, we try to help them collaborate. No one wants to lose their parking space, to go find partners. So we build partnerships and we have community connections. We're gonna hear a little bit about that today. But we also are very, very intentional about doing high quality research itself is the goal. And so we know that as faculty members and administrators and staff at Texas State, nobody has free time. And the administrative burden of some of the things that you want to do can be shared with us. And we have such a great staff that does a lot of work to develop these programs in ways that connect us with community organizations. Right now, more than ever, in my opinion, we have to demonstrate the value of what we do. And a journal article is critical. That's a metric and a way that we measure internally, but the world measures in different ways. They measure with impact that is outside of academia. So the more we can have community partners engaged in our research, and the more that we can use resources like the librarians, that in my former institution, so many of our grants included librarians, because anything that was information that needed to be disseminated or needed to be implemented, or there was data, a million things. So thank you to all of the folks from the library that are here today as well. We have two really, really good speakers, and they are both affiliated with our center. And the way that people become affiliated with our center is we are not a funder, but we're interested in a relationship. And so we look for people that want to actually work with us and do projects that are mutually beneficial. And I think that we definitely hold up our end of the bargain in terms of bringing value to the work that you do. And so what we don't have are our own faculty researchers that are internal. And so we rely on faculty at Texas State to partner with us to do research to make sure that our mission as a research center is met. And in the beginning, to facilitate that, we started the Health Scholar Showcase. This is where I used to say I wanted it to be a research dinner party. We hold it at the Performing Arts Center, and it's a different kind of event. It just looks pretty there. The light's good. And so this year we have a speaker from Will Corning Medical School. He's in the Department of Psychiatry. He's a really interesting guy because he was in the film industry before in LA, has a master's from USC Film School, and then he became a psychiatrist, and he hosts a really successful podcast. So he's very, I could talk to him all day, and I think he's going to be a great speaker, and I hope that you will come to the Scholar Showcase on April 4th. And if you have people that want to know how they plug into this kind of a group or to our center, the front porch is the Health Scholar Showcase, almost always, and we hope that we will see you there. Okay, so up first we have Elizabeth Ekren. Elizabeth is a research scientist in our center, and she is the lead on a grant, and she is the lead on a portfolio that we have that just kind of happened organically with some partners in East Texas. She's going to talk about that. Elizabeth, okay. Slides.
Well, hi everyone. I'm Elizabeth. Thank you so much to Dr. Villagran for introducing me. As I spoke briefly before, my background is in development sociology, and so kind of over the course of my research career, I've had the chance to look at a variety of kind of policy, place, and personal circumstance-based topics and their impact on different sorts of well-being outcomes. But today, I'm really excited to talk a little bit more about the current work that I'm leading at TRC, really on issues of rural healthcare access and outcomes in rural communities in Texas. And I think as rural health disparities in Texas grow, THRC as a center is looking to kind of expand knowledge and insight into this topic. We really believe that it is a topic that lends itself well to a variety of perspectives and disciplines, and I think that that's kind of how our collaboration model works here. And so today, kind of my goal is to just give you a broad overview of the work that's occurring right now that I'm working on in conjunction with Dr. Malecki. She introduced herself earlier, as well as Dr. Villagran, but also in conjunction with two regional partners. That's the Northeast Texas Public Health District out in East Texas, and also the TLL Temple Foundation. I'm not going to go too in depth into kind of the results of some of the work that we're doing, but I'm going to present some overviews and kind of some key findings that I think could be impactful. I was really excited actually to hear all of the introductions. I think that was a great idea because it kind of got my brain going about how we might all intersect and how kind of this particular project actually intersects with a lot of the things I think you all are interested in and are doing. So that's really exciting to me. So I'll give you an overview of this data, kind of give you some top line findings from some of the analytical work that we're doing. Talk a bit about our next steps, where we're hoping to go, and then I will turn it over to my colleague, Dr. Perez, who I think is a really great example of kind of how we're elevating this nexus of place and health. He does work more at systems level, looking at kind of place-based factors and how they impact preparedness and healthcare outcomes from a modeling perspective. So I think that it's going to be so I think all of us in the room know that, health is of course influenced by our personal choices, by our genetics, but, place, of course, where we live, grow, eat, sleep, age, work, that really has an impact as well. And, these conditions of place are often referred to as the so-called social determinants of health. But I think regardless of what you call them, this research in particular and at THRC, we really believe that health is influenced by place, and health is influenced by that wider set of local forces and systems, shaping the conditions of our daily lives. Rurality is one element of place, that shapes and touches on all of these dimensions here. These social vulnerability framework, and across all around the world, all of these different conditions interplay on one another to affect healthcare access and outcomes for rural populations, such that we see a lot of disparities in rural populations that we don't see when we necessarily compare it to urban populations. So make sure I'm covering all of the points that I want to cover. So, all of these different factors work together. Obviously, things like education and access to different jobs can affect things like your access to insurance and your income, healthcare quality and access. Rural areas often just simply have fewer services available. Different factors of the built environment, where you can exercise, providing nutritious food, or the kinds of transport you can take to get places. All of these things kind of build on one another to influence the types of care people can seek, how they can seek them, and ultimately the health outcomes that they face. And Texas, unfortunately, isn't really an exception to these trends we see around the world. There's a lot of indicators of kind of health behaviors and health outcomes in rural Texas that are worse when compared to urban populations or populations overall. For example, individuals in rural Texas tend to suffer from higher death rates from things like cancer, heart disease. There tends to be a increased prevalence and severity of different chronic conditions like diabetes, heart disease, COPD, and in many cases, these are linked to kind of elements of place. For example, around rural counties make up around 80% of counties in Texas, where over 20% of people live in poverty and over 20% of the population lacks access to insurance. Similarly, rural hospital closures have been increasing at alarming rates since about 2005, and that really limits access to essential services like maternity wards, emergency rooms, surgical centers, and things like that where people can get care. So I think with that setting in mind, and with that gap in place, that was one of the reasons that we wanted to undertake this kind of novel research. But I think in addition to that, so in addition to just the problems going on and the disparities that we're seeing, rural voices sometimes can be really hard to access actually with data. We found that with some larger cross-sectional data sets, sometimes there just aren't enough responses from rural areas, especially remote areas, to kind of be able to make meaningful rural-urban comparisons. And then I think even in addition to that, in the databases where there are sometimes more responses, you can't necessarily disaggregate those responses down to a zip code level or a county level or a census tract level. And so it's going to be really difficult to do kind of locality or place-based research. And so that kind of underlined the purpose of this data that we were collecting to really have and start building a data set that was very community focused, that could kind of tell us more about qualities of place, qualities of residence in very, specific individual communities, to have a more, I think, localized way to approach looking at this kind of very complex problem of rural health disparity. So our study area, the data set that we've been working on right now, it covers 22 counties in rural East Texas. All of these counties are in the public health region 4-5, which was the service area of our community partner, NetPHD. So that is their service area. And kind of when we were conceptualizing this project, we felt it was going to be really important to involve a community partner, a practitioner partner, not only just for insights and the value that they could bring, but also potentially for data collection assistance if we needed it, and we did end up using them for that. Additionally, this also interlaps with the service area of the TLL Temple Foundation, which is another partner of ours, and they were interested in getting similarly some more localized data that we could really kind of hone in on and look at things that were going on in their particular service area. The survey that we constructed, so it's a novel survey, but we drew 50 questions from pre-validated sources, so mostly NIH sources, CDC, CMS, survey sources, and we cover quite a few domains, so kind of key demographics, social determinants of health, some trust and health information variables, and then as well as kind of those 4 set of questions on health status and health outcomes, which are what we're healthcare seeking behavior, which are our kind of main outcomes that we're looking at. And so far, through 2 phases of data collection, we've gathered almost 600 respondents across this 22 county, 115 zip code area. And we've done it in 2 phases. So we have 1 phase of data that comes from a Qualtrics online panel. So if anyone is interested in learning more about Qualtrics panel research, I'm happy to talk more about that offline. And then the second set of data we collected was actually a little bit more specific, and we did in-person survey recruiting with our public health partners, so with NetPHD, and they collected survey responses from around 160 women, so women only, who were clients of their WIC clinics or other public service campaigns that they were running. So from all of this data, I think we are really kind of interested in looking at, I would say, kind of 4 key themes that are kind of bucketed around the items that we collected in our instrument. But I think the top line theme that we're really looking at is kind of this idea of social vulnerability and different sorts of access barriers. In this case, we're looking at things like housing, transport, income, insecurity, access to insurance, and then kind of also some of those key socio-demographic categories, employment status, education, age, things like that. And then kind of secondly, we're looking at kind of this intersection also between health status, care needs, and care use. So that includes things like, are people getting the care they need when it is needed? How many types of care are they getting? Are they using kind of the right level or source of care on what issue they're experiencing, or can they get to the right place when they need to get there? And then we have some kind of poor health status questions. And so we're looking at this middle theme here, this health status care needs theme, both as inputs and outputs. And so we have a little flexibility in our data set, so look at it that way. And then some kind of other interesting things that we're hoping to look more into is just kind of this, how the sort of nexus of trust in providers and trust in different types of health information sources maybe compels people to overcome some of these resource and kind of barrier challenges that they're experiencing. Obviously there's a lot of literature talking about the power of kind of the provider-patient relationship. And so we want to know maybe how trusted providers or maybe trusted information from a variety of sources can help act as a conduit to solve some of these other vulnerability challenges. And then finally, the last thing being, what kind of is the impact of just different measures of geographic resource availability? So how far people are away from different types of services like emergency rooms or pharmacies, but kind of also how population level indicators of resource scarcity or vulnerability align to shape kind of the care behavior. So as I said, I'm not going to go too in detail to the specific findings that we're looking at, but I definitely want to share some top level themes that I think we're finding really interesting and impactful, and hope to continue to develop as we finalize this analysis and maybe look for new collaborations. I would say the primary top line theme that we've found is that, yes, social vulnerability does influence different dimensions of care outcomes. I think that was an encouraging finding in the sense that it's always nice to sort of confirm what you see in literature in a case study setting. In that way, but we did find that people who rated themselves as more socially vulnerable did indicate being less satisfied with their ability to get healthcare and got care less frequently when it was needed. That also included experiencing more barriers to getting care, so things like affordability, concerns about quality, logistical difficulties in getting care, that also had a similarly significant impact on outcomes. And then finally, being away from a lot of different kinds of resources also impacted people's satisfaction with getting care, which I think is understandable. I suppose surprisingly, we didn't actually find a large impact of various socio-demographic variables kind of on some of these top line findings. And I think we were maybe surprised in a way because, we know that different groups of people experience these sorts of vulnerabilities in different ways. But I think for us, this was also encouraging, just kind of from a storytelling perspective, because, we're able to tell the story that these types of factors and vulnerabilities affect, people in rural communities. We don't need to somehow append these sorts of issues or challenges to only a specific group of people. And we think that maybe, especially in this climate, offers a way to not push this issue under the rug, and not simply say, well, that's just an issue for old people, or it's just an issue for whatever fill in the blank type of person. No, this is really a community-based issue. It's a rural-based issue. These challenges are there for, all of us to experience, yes, in different ways, but they're there for all of us. So I think that's an encouraging way to tell the story. We did have a little bit of a chance to explore kind of the nexus of health status, care needs, and vulnerability in that more specific data set of just women using WIC services. This particular example of analysis, I think, was a nice way to tell that story of the kind of self-perpetuating link between, resource scarcity, not being able to get care, and poor health outcomes. So we did find that greater social vulnerability in this group of women was associated not only with more difficulties getting care, but also lower health status overall. And food and transport insecurity in particular played a significant role in this data set. And I think a nice use case for this type of finding with our net PhD partners is to kind of tell them, well, you may have different types of people or different groups of people in your service area who are maybe experiencing different vulnerabilities kind of intersecting with one another. Could there be kind of intervention points to target to the most vulnerable groups, or, are there ways to maybe solve some of the transport or food insecurity problems? Maybe that might go away to being a more relevant intervention. And so, I think that also was a purpose of collecting this type of data to see if there were just more, relevant entry points for proposing solutions that could be just, more resource sensitive in rural settings where I think a lot of solutions that would be ideal just might not be very feasible. For example, sure, build back the rural hospitals, but that will take a very long. So kind of on that note, another line of analysis that we're looking at is, how can resilience, a topic very dear to us at THRC, how can resilience, the ability to cope, to solve your daily problems, kind of work through daily challenges, can that mitigate some of these effects of social vulnerability that we're seeing on health status overall? And I think that we like this way of thinking because we can look at resilience more as a tool. It's not necessarily saying, well, just physical resources or just social resources or just clinical resources, but how can various things that could work in different areas that just enhance someone's capacity to sort of cope through their problems and overcome challenges, how can that mitigate the effects of vulnerability? And so I would say to see the results of this, come to the Health Scholar Showcase. I'm going to present on this particular line of analysis, but again, I think I wanted to show it and share it just as an example of how we can use this type of place-based data to maybe think about interventions or telling stories about entry points for interventions that could be more relevant in rural settings. Similarly, we're going to be looking at these kind of trust and health information variables that we have. My colleague Lauren Lee is kind of going to be leading that. But we know from literature, especially I think in rural health literature, that the patient-provider relationship can have a lot of power in terms of helping to motivate people to, uptake different sorts of care decisions, or maybe find ways around some of the barriers they're experiencing to undergo certain care recommendations. And so we want to find more out about how vulnerability and maybe even chronic illness status is influenced by that patient relationship or that patient provider relationship. And I think similarly too, we're interested to learn, can, working with a trusted provider or maybe trusted local sources of information maybe help mitigate some of the negative effects or the negative distrust maybe in national level information or external information that people are maybe feeling a little bit pressured by right now. Can having a good relationship with a trusted provider maybe help overcome some of those difficulties. So more on that line of analysis soon. And then finally, we are hoping to do some comparisons, I think, between individual kind of level indicators of vulnerability and access and compare them with more population-based levels of vulnerability. So on this side of the map here of CDC's social vulnerability index mapped across our study area, that is a population level indicator that's taking 16 different dimensions of kind of vulnerability and resource scarcity, but at a population level. And then we've kind of compared it on the other side to our sort of a summary of a self-rated score of vulnerability from our respondents. And so this map kind of shows that there's congruence in some areas. In some areas, people kind of perceive themselves to be as vulnerable as the index might predict. And in other places, there isn't really as much congruence. And so we're kind of interested in this to examine why is that, kind of what is going on, and can we use these types of, data disparities to maybe inform local stakeholders about when they ought to bring more local perspectives maybe into their intervention making decisions. This idea actually stemmed from a comment made by our partners at NetPHD. They kind of said, well, how does this local data compare to like the SVI, for example? And we said, well, hey, that's a great question. So when we started to look into it, we noticed, well, some of these similarities and differences, and some other work that's actually looking at comparing individual level indicators of vulnerability with the more kind of consolidated population level ones. So we're going to be looking into that and seeing where we can kind of take that line of thought as well. But I would say kind of what we're hoping to do with this right now. So obviously finish up all those different lines of analysis that I just shared with you. And close out this phase of work with our two partners with NetPHD and TLL Temple. Our next phase of work with NetPHD is going to be a bit more solutions oriented. So we will be kind of taking the findings from all of this data and working with them to host some panel interviews with local experts. So that's another great value that they're providing to us, is they are really helping to recruit relevant local experts, kind of local politicians, local heads of health systems, local medical providers who I think have very particular insight into maybe what place-based solutions may or may not work in their areas. So those interviews are going to be very solutions oriented. And then I think really the next thing is, one of the reasons we brought this topic to this lunch and learn today was just, we want to kind of open it up to ideas for collaboration, open it up to, maybe some joint approaches to seeking some funding and where there's interest. But, I think I was really encouraged by the introductions to hear how so many of you are examining already this nexus of, policy, place and personal circumstance. And so, I think there's a lot of room for overlap in this work, for expanding it, for taking it to different phases. Eduardo is going to talk about, or Dr. Perez, is going to talk about just some ways he's doing that, not exactly based off of this, but in his own context. And so, I'd love for you to reach out to me to learn a little bit more. If you want to learn anything more specific about any of this, I'm happy to talk offline about that. And if you just want to learn more about rural health disparities in general in Texas, get your ideas going. I have a little QR code linking to a paper we just published that just talks about it from a state-based perspective that I think could be really informative. And so, I really, really hope you'll engage, and I'm looking forward to hopefully talking with more of you. And I think with that, I will turn it over to Perez.
Thank you. Kind of alluded to this, but for me, some of what she said that is really critical is that in this era of a shift away from some of the things that we've all focused on for a long time in disparities, rurality matters. And rurality is something in Texas that especially matters for health, because we have 44 counties with no hospital. And so you ask, as a researcher, I ask, what could be in it for partners? So TLL Temple, they need news. They're a regional foundation, and they want news about what's going on here. How are we different? Because the legislation is in. And they want to bring attention to the fact that they need healthcare and that trust in for local providers is really critical for health there. And so having this data set that they were able to sponsor and bring in news is big. And then taking the data, we're sort of doing a little sneak workaround by having these focus groups where we're gonna gather additional information, but they're elected officials, healthcare officials, and community leaders. And what that is gonna help us do is inform them about what is going on. So that because they have more standing to help make these changes and to raise these issues. And we're gonna give them actionable data about their own localities so that they can go out and tell the story to try to improve the situation that was, found in the research that Elizabeth and Shadi and others are doing. So it's mutually beneficial. And I think that model is something that we like to try to highlight to show how you can find partners that want to work with you to find ways to make it mutually beneficial, but thinking about what do they need? They need news. They need new data. What's going on here? I don't care about the rest of Texas. And also that rurality is a critical opportunity for people to look at places where there are disparities that still don't raise concerns that we are experiencing now. So anyway, thank you for that. Yes.
So compliments on this work and also to the THRC and I see some consistency of some really I see Shadi's hands on this great work
100%.
that's being done up there and so I was just curious if there is research to policy funding the Texas state has with this, if that is something that we are working on to make sure that this very important research is getting in the hands of the Texas legislature during this session.
Let's talk offline, but I have a couple of answers to that. I think there is there are some avenues. Just last week, Jennifer Speed and I were in the Capitol for a meeting about dementia and Alzheimer's research funding. And we also went with Elena and Dana's not here to UTEP. And they have a center that has a really strong policy and health economics focus that wants to partner with us. And so we're trying to find ways to plug in the policy and health economics, because the economic argument, if anything is cost effective, that's always a good argument to move it into policy. And so we've identified partners to help do that, and we will be able to support those kinds of activities. So we'll talk. I don't want to take up too much time because I want Eduardo to. Thank you. Yeah, but that's great question. I mean, we're thinking a lot.
So before we get started, I want to give you a small, short history of how we got to this point in terms of research. Well, I did my PhD in industrial engineer, bachelor's degree at PhD level. My dissertation was focusing on a cancer center project in which we're trying to schedule patients to go through the system efficiently, and they can get the appointment schedules and then better treatment in the right time, right place, and see better outcomes. So during my tenure track, I kind of follow up on that same strategy, looking for partnership with hospitals. I went to Brody on an application for hospital infections and patient infections, and work was mostly focusing on how can we help this hospital to be more efficient so we can improve outcomes, right? But then after my tenure track, I had the opportunity to do my sabbatical and work with the public health department with NYU. And then I had an interest in seeing how can I get this research outside a specific hospital so I can make a larger impact. So how can we get to, let's say, build on what we know already so we can help more people at the public health level. So that's how I got to this project, right? In which we are not necessarily focusing on improving a service that is provided by a hospital, but now we are looking at the city level, the state level. How can we use these tools, these models, these decision-making models to have an impact on the life of many people in society? So So this is one of those applications that I've been working on, an agent-based model to assess the interventions for continuous care of cardiovascular diseases after natural disasters. So this is a project that was born during this sabbatical that I did. And now we're taking this to the next level by looking into resilience and natural disasters and how can we build a better system for people that are impacted by not only hurricane, but maybe man-made disasters in the future. So we can plan ahead, have these tools and say, okay, if this happened, this is the best way to go. These are the things that we need to be ready to implement in case this happens. So that being said, agent-based simulation is just one type of simulation model. I decided to use this one because I'm gonna talk a little bit about that in a minute. For this particular case, but this is not the only simulation strategy that we can use for these different type of projects. One more thing before I get started. So the idea is also with this presentation is I know we have people from different departments. If you see that there's value in terms of having a decision-making model as part of your research, reach out to us. Right? You see, like I'm dealing with this problem. I would like to know with some type of forecast. Oh, if I do this, what's gonna be the impact? That's the type of work that I do on my students. So this work is what's done with my student, Faria. She actually presented this in a conference in December, and we got a paper published on this work. And this is the motivation, right? So as I said, there's in the literature, there's two different research directions that are connected to this research. One is looking at the immediate impact of natural disasters in the healthcare delivery for patients, and that's being studied and documented. So if this happens, it's 2 weeks from now, this is what you're gonna see, this is what we need to do, or this is what needs to be ready after these 2 weeks. But these long-term effects of disasters on healthcare systems is not being studied already, right? So that's the type of question that we are trying to answer. What will be the impact, like you are living in an area that you see a hurricane every 5 years? Is that having an impact on your health outcomes in the future? What if you live in an area in which you need to go to a shelter every time you have a hurricane? Is that transition to going into a shelter or moving to with a family or moving outside the state? Is that creating some type of disruption in your treatment, in your medications? And what type of impact are you seeing, let's say in 5 years, 10 years from now? So that's the type of question that we are trying to address with this research. And we're specifically looking at some chronic conditions. This research is looking at heart disease, cardiovascular diseases, and we also have a portion of it that is looking at diabetes as well. So critical problem in the resulting health crisis is the inability of displaced population to manage their chronic diseases, and this is being published in one of our references. And I'm raising some of the information that we found in terms of Hurricane Katrina that was very well documented in the literature, so that's why we are using that case. CDC reported that chronic conditions accounted for 5 of the 6 most reported conditions after Hurricane Katrina. Number of individuals with 1 or more chronic illness diagnosed in the Houston shelters after Hurricane Katrina was about 41%. More than 45% of evacuees did not bring their daily medications to the shelters, and more than 2/3 of medications provided during the response were for treatments of chronic diseases. So as you can see, there's things that we can improve in the way we manage these natural disasters. So another thing here, that's not the only important factor in terms of disruptions and in terms of building a resilient system. Like we are focusing on specifically maybe not having access to treatment and medications and so on. But there's other things that can impact the resilience of your system, like damage to infrastructure, maybe illness that will come after the hurricane, like mosquito bites and so on. Mental health is another important, as we've been discussing that previously. And then as we saw in the previous presentation, social determinants of health. So there's so many things that we can address for these type of problems that shot. So we did a little review. We studied many papers, and this is how our research is different. So I'm not gonna get into the details, but there's opportunities for building tools to help plan for a better way of approaching treatment for our citizens, specifically in Texas. So, what in terms of this particular part of the project was to develop an agent-based simulation that forecasts the impact of healthcare outcomes of individuals suffering from CVD after or during after natural disaster. And we want to use this model to help identify clinical guidelines for effective healthcare delivery prior, during, and after the disaster events. So one of the things that we specifically for this presentation, that we tested was what will be the impact of setting up different mobile pharmacies close to or get them ready first, and then in the place in specific areas so they can serve people in, let's say, in a shelter in Houston Convention Center. So going into the details, again, I'm gonna put this in very high level, because we don't have a lot of time. But we built the simulation, and actually I have a video that I'm gonna show you in a minute possible. So the agent-based simulation model developed in Logic. This is a very good software package because it allows you to build a Java application. Like if you're working with, let's say, with the government, they don't need to have access to the software. You can build a Java application for them based on your model, and they can use that Java application for making decisions. So that's why one of the ways that I think this is very impactful, that we can take this to, let's say, let's call it a client, say this is the tool, this is what you can use to make decisions. And the emergent health counts mortality for a certain population. So what I'm showing here is just the visual interface. But the idea for what the model does is it looks at each person as an agent. Each person in the model will have an individual behavior, and it's going to be based on the information that we have from the population that we are studying. So for example, each person or agent is defined according to 3 health behaviors: smoking, physical activity, and diet. And the 4 health factors: body weight, cholesterol, blood pressure, and blood glucose. So each we're providing the model with, let's say we're studying the area of Houston, we're looking at an area with 5,000 people. And these are the demographics of the population in terms of age, gender, and many others. And then we provide information in terms of statistical evidence that's been published in terms of if you are in this age range, if you're a female and you have this body weight, you suffer from these conditions, this is the likelihood of you transitioning from where you are right now to these other health conditions. Or is the potential outcome, let's say every year you have a transition probability of moving from where you are right now to another health outcome. So let's see if this works. I didn't test it. It's showing up in the screen, but not. Hey, so I can show you the video if you're interested later on.
I can do it real quick.
Yes,
Is that what you-
yes. I know we don't. It is. What is that? It's okay, I can, yeah, that's, if you're interested in this video, the video, yeah.
The simulation model impact thing, definitely check it out.
Yes, yeah. Here you go. There's no volume. Yeah, there's no sound. The purpose, yeah, evaluation, they know. I think if you look at the.
I'll get one second out there. Share with you. And we're there, is gonna be next year on a winter cycle. He applied to have a cycle with our center, so he's gonna be able to be a faculty fellow with our center full time for a year. And so if you know anyone that is applying for a sabbatical that wants to do something like that, apparently it went over favorably and.
You just work with either the 1 semester or 2 semester model.
Yes, and we're gonna give him some space to kind of get away from his regular environment so he can do his research and some support, administrative support and other things. So, yeah, just putting that out there. Thank you, Eduardo, for doing that. We're thrilled.
So yeah, here's the. There's some factors that are coded into the population, and then we added for example, smoking, diet, physical activity, poor weight, cholesterol, and so on. And we also have some coding in terms of the impact of the natural disasters. Then this is the way it works. When you run the simulation, you'll get into a visual interface in which you can input the parameters associated with your experiment. Like in this case, we get information in terms of the total population, age, in terms of mean standard deviation, meaning the maximum percentage of people that are female, smoking, normal BMI, physical activity, certified diabetes, and so on. And then we can also look into how many years we want to study and the years in probability per year. When you run the simulation, you get this, the showing interface that is showing in green, the people that have no CVD outcomes, MI will be red, stroke will be yellow, that will be black. So this right now is running for 25 years. We're keeping statistics real time. In this is building some statistics in terms of the outcomes that are expected after 25 years of running this experiment. So again, this is a specific case. We can build this, study different population, different interventions, different probabilities for natural disasters and so on. So that's the idea of the tool. And then, sorry. What I'm going to do now is to show you the results of one of the outcomes. Wait.
Doing great, Toby. Thank you.
So this is the information again, and this is more information on what we just saw, right? These are the code, right, in terms of how the behavior of the citizens, say this project will work. So we have health behavior, health factors, and then we also have a line of code that is looking at if you're on a specific area based on those behaviors and factors. There are chances of moving from no CVD, MI, stroke, MI death, or stroke death. Right? So there's a chance that you go from this line, or maybe at some point you just die for natural reasons. So that's also a possibility within the model. And then we have the space right here, space transitions for here things, the way we're modeling this. is every year there's a chance for you to, if you're on an area that is prone to hurricanes, there's a chance for you to face one of these events. If in the particular area that happens, and you move into this area in which you might be needing to relocate or not. If you're relocating, then there's a chance of you bringing your or getting access to your health treatments or not. And then all of that is also connected to what's gonna happen with your health factors and also connected to your potential outcomes. Okay, so here's some information about how we evaluated the model. We are running out of time, but we use precision of probabilities for all stage charts and the correlations among different factors that were estimated based on published studies. And then we use the national representative data from the behavioral risk factor surveillance system to do our validation. So here's some of the information in terms of validating our model. Our results were very close to what was observed from the data published from year 0 to year 5. So we use a 5-year period to run the model with year 0, and then after 5 years, we compare our results, and they were very close. And then we use the information from the literature to quantify things like, okay, what are the chances of you, if you're in Texas, for example, current chances that if you experience a hurricane, the chances of you getting your medication. So all those data points were obtained from the literature, and we inputted that into our simulation model. And we also look into this particular case in which we are looking at the probability of hurricane and how we evaluated the events in terms of having a hurricane and how would that impact the outcomes. So what we did was we looked at specifically at Houston, what is the probability or average yearly hurricane impact probability. We saw that that was about 16%. We added that as a parameter in our model, probability of relocation, probability of no medication, specifically for Texas. And then we ran the simulation for 25 years. Here we are reporting the years that the simulation obtained or added hurricane event. And we were able to measure or the difference between when no hurricane versus when you're experiencing a probability of 16% hurricane per year. What was the increase of the percentage of CVD deaths? And then we obtained that on average, that's about 14%. The reports that average increase in CVD outcomes due to a natural disaster is about 15–16%. So we were also really close. And then we ran some experiments in terms of, let's say we want to observe what would be the impact in the Houston area when we have a yearly probability of 16% of getting a hurricane. And also we got that Texas in general as a state had a 41% probability of experiencing a hurricane with an average of annual probability of 26%. So we use those three. Houston, Texas as a state, and then the average and the current year probability of experiencing an event to run. Okay, if we are under those three scenarios, what would be the impact in terms of the number of CVDs for 25 years? And as we would expect, that number will increase. Remember, we are focusing on specific population. We are not adding more people to our population. Let's say this is the 5,000 people that we started with, and this is the analysis for them. So as you would expect, this will increase. That's not nothing that we not expect, but what we did in order to see okay, what would be the impact of, let's say, having these mobile pharmacies close by, providing the medications that the people will need. And we established that intervention, the impact of 10% increase in medication adherence and supply, 15% and 20%. And what you're seeing here is just the percentage of CVD death reductions. So what we observed was that the most substantial impact of the intervention is seen at the earlier years, like first 10 years. But then if you sustain those efforts, you'll see that there's still an impact happening until you get to the 25 years. So in conclusion, we have developed a tool that is built to try to forecast the impact of natural disaster and also to help develop interventions to make our systems more resilient, specifically at the city level for an area that is prone to hurricanes. And the tool and the model is able to be adjusted based on the type of event that you will need, based on the population that you are trying to study. And it's helpful in terms of forecasting not only what will happen if nothing is done, but also to try to measure the impact of the interventions that you might propose to solve the problem. So in the future, we are currently working on preparing a proposal for NIH collaboration with the center. And we are also exploring other factors that are impactful in terms of measuring resilience for Texas. And we are also trying to incorporate other type of conditions into our model, trying to explore other conditions like physical conditions, but also with the idea of the future integrating mental health. So that's it.